Today, we'll continue with infectious neurologic disorders and look at brain abscesses. Introduction. Brain abscesses are rare, accounting for less than 1% of space-occupying brain lesions in the U.S. They occur most often in patients who are immunosuppressed, either from disease or from immunosuppressive medications. In immunocompetent adults, the most common predisposing conditions are otitis media and rhinosinusitis. In fact, 40% of brain abscesses are otogenic in origin. Other causes include intracranial surgery, penetrating head injuries, even tongue piercing. Organisms can also spread hematogenously from the lungs, gums, tongue, or heart, or from wounds or intra-abdominal infections. Pathophysiology. A brain abscess is a collection of infectious material within brain tissue. Bacteria are the most common cause. Once infection develops, the abscess causes edema, brain shift, and increased ICP, leading to clinical symptoms. Clinical manifestations. Symptoms depend on the location of the abscess and the effect on intracranial dynamics. Most common, headache, often worse in the morning. Mental status changes. Fever, present in about 53% of cases. Vomiting. Focal neurologic deficits, weakness, vision changes depending on site. As the abscess enlarges, signs of increased ICP appear, decreasing LOC, seizures. Baseline neuro exam is key. Findings vary by abscess location. See Chart 64-1. CT with contrast is often first choice for diagnosis. MRI gives better resolution and detects additional lesions. Aspiration, guided by CT or MRI, allows for culture and identification of causative organisms. Blood cultures may help if a distant source is suspected. Early detection of cerebritis is important. This small infection can progress to a full abscess. Chart 64-1. Abscess location and symptoms. Frontal lobe, expressive aphasia, frontal headache, hemiparesis, seizures. Temporal lobe, receptive aphasia, vision changes, facial weakness, localized headache, cerebellar, ataxia, nystagmus, occipital headache. Medical management goals. 1. Control ICP. 2. Drain the abscess. 3. Provide antimicrobial therapy. Treatment. IV antibiotics in large doses to penetrate the blood-brain barrier. Usually start with ceftriaxone, metronidazole, then adjust based on cultures. Stereotactic guided aspiration, both diagnostic and therapeutic. Surgical excision, only if abscess is large or multilobulated. Corticosteroids may be used to reduce cerebral edema if neurodeficits worsen. Anticonvulsants, for seizure prevention or treatment. Nursing management, ongoing neurologic assessment, monitor for ICP changes, seizures, or new deficits. Medication monitoring, watch for effects of antibiotics. If corticosteroids are prescribed, monitor blood glucose and serum potassium, may need insulin or electrolyte replacement. Safety precautions, protect patient from falls or injury if LOC decreases or seizures occur. Supportive care, address hemiplegia, hemiparesis, visual deficits, cranial nerve palsies. Family support, assess coping, provide education, connect with resources. Prognosis. Patients with brain abscesses are critically ill, but outcomes have improved. 70% of patients have no or minimal long-term neurologic deficits. Some deficits, motor, visual, speech, may persist, requiring rehabilitation and family support. More research is needed on long-term function and recovery.